a higher prevalence. And so this is quite encouraging, the fact that our trend is coming down. And that's why it's very important that we know exactly what to do, how to make a diagnosis of malaria, and then how to manage it when we do make that diagnosis. And when our RDT is negative, what do we do? Do we go ahead and treat, or we don't treat? Right. So as I mentioned earlier, malaria is endemic in Ghana. And if you take all our health facilities in Ghana, if you were to put the top 10 diagnoses in Ghana, you would find malaria amongst these top 10 diagnoses. And if you look at, in terms of even the costs to the economy, the NHIS pays a significant amount of money every year for malaria diagnosis to health facilities on account of malaria. And so malaria is quite important to us. Even though we've seen the declining trend, it's still very important and significant. Another thing that's interesting is that malaria has non-specific symptoms. You have headache, fever, joint pains, chills, bitter taste in the mouth, none of which are particularly say pathognomonic for malaria. You cannot say that with these symptoms it is definitely malaria. And so it becomes important that you do a test to be able to ascertain that this truly is malaria. It's not enough to just have symptoms and say, clinically, I suspect malaria, and therefore I'm going to treat as malaria. And so the policy over the years has changed. Previously, when we had a very high prevalence and not enough access to testing and all that, it was enough to just, as a clinician, see a patient who has symptoms that seem like malaria and to start treatment. But now we want to test everyone that presents with symptoms like malaria. We want to treat them. And when we have treated them, we want to track them. We want to see where these cases are coming from, what interventions have failed, what interventions could have been put in place to prevent them from getting malaria. And so this afternoon, we're going to follow this outline. We're going to look at how to diagnose malaria, what the guidelines say about the management of malaria, what our challenges are with diagnosing and managing malaria, and whether to treat or not to treat when our RDT is negative, and then we conclude. So we'll take a quick look at the life cycle of the Plasmodium parasites. First, we have an infective Anopheles mosquito that comes to take a blood meal from a person and then injects these sporozoites into the bloodstream. They find their way into the liver, where after some time, after multiplying, they are released into the bloodstream to undergo the asexual stage of development. And so they go through these various forms, the ring stage, trophozoites, schizones, and merozoites. And these are the ones that when you do a blood film, you would see, as well as the gametes. The gametocytes are picked up by another mosquito during another meal. And then if that mosquito goes away to bite another person, the gametes may complete their life cycle, the sexual stage in the mosquito. And then when that mosquito takes another blood meal, may infect the new person that has been bitten. So bearing this in mind, we'll proceed. To diagnose malaria, the current guidelines are saying that 100% of all suspected cases of malaria must be tested. And so it is not enough. You cannot have a diagnosis of malaria without having done a test to say that, yes, this is malaria or not. And so all patients, you cannot afford to now just make a clinical diagnosis and say, patient has these symptoms, therefore it is malaria. You need to test every single person that you suspect has malaria. And in order to be able to do this, various interventions have been put in place to be able to increase our capacity to be able to do this. And so in every Ghana Health Service facility, and even others that may not be Ghana Health Service directly, various laboratory technicians and scientists have been trained and certified. There's a WHO certification that they need to do to be able to say that they can confidently pick up malaria parasites on a blood film. And that has been done nationwide, and it's an ongoing process. They do refresher trainings. And so if you have a microscopist who is certified in your facility, then I encourage you to have some confidence in that reports that you are getting from them when they tell you that there are so many parasites present or there are no parasites present, because there's a systematic means of training them and getting them to be able to give us these reports that we can trust. Also, we recognize that even in the facilities that may have these people who are trained, we may not have access to their services 24 hours or around the clock. And so rapid diagnostic tests have been developed and deployed. These rapid diagnostic tests work on the principle of immunochromatography. And so you have different test kits that are impregnated with antibodies to various proteins that are found in the malaria parasite, so that if the parasite is present, antigens from the parasite may cross-react with this to be able to give you a positive test for you to say that truly the parasites are present. So when would we say that a person has malaria? The person must have a fever or a history of fever, a recent history of fever. So within the last 2 to 3 days has had a fever and has evidence of malaria parasitemia. Now, before we jump to conclusions here, we have to bear in mind that when you are making a diagnosis of malaria, the program enjoins you to not just say that malaria. You should be able to classify and say whether this malaria is uncomplicated malaria or severe malaria. So in order to say that this is severe malaria, that person must have evidence of vital organ dysfunction. So if it's the brain, the person may have had seizures or altered consciousness. If it's the kidneys, the person may have oliguria or evidence of an acute kidney injury. If it's the lungs, they are having respiratory distress syndrome, or they have signs of severe disease. So if their general state is such that maybe they are very lethargic, or they vomited so much that they become severely dehydrated, or anything that makes you classify this person as being very, very ill, would make you classify that person as having severe malaria. And then for uncomplicated malaria, they have a fever with evidence of parasitemia, but would not have any vital organ dysfunction. And they need just one evidence, either a sign or a symptom of a vital organ dysfunction, to be classified as having severe malaria. So to make the diagnosis, microscopy is the gold standard. This is because with microscopy, you can actually see the parasites. And so, like what I mentioned earlier, you would be able to tell what stage these parasites that you are picking up on the film are in, whether it's gametocytes that are there or they are schizons or trophozoites, you'll be able to see on the film. The microscopy, so every laboratory is expected to do 2 films for every patient. They do a thick film and a thin film. So you should find out from your laboratory, what are they doing? Are they doing both? Because that is the standard, that is what is required. On the thick film, they'll be able to quickly tell you that there are malaria parasites present. On the thin film, they can tell you what species it is, because remember I mentioned that falciparum is what causes the most severe infections and it's what causes the majority. But there are cases where you may have a co-infection either with malaria or ovale or even vivax being present. And so you need to ask them to do the thin film so that they can tell you this, what species it is, what the parasite count is, and what stage they are in, because all of these have implications for your management. And then for the rapid diagnostic test, like I mentioned, it uses immunochromatography. So all these cassettes have various monoclonal antibodies that would cross-react with antigens from the parasite. And there are Plasmodium falciparum specific antigens like the histidine-rich protein 2, HRP2, which is what is found in majority of the RDTs that you would find on our market. There are others that are also that contain other enzymes like the aldolase or LDH from the Plasmodium parasite. And so it's not just for falciparum, it may react for ovale or vivax, or if all 3 are present, it would show also as all 3 being present. And so you need to understand this in order to be able to tell whether the test you have done is truly negative. It may be negative for falciparum because you are using an HRP2, which is picking up only falciparum. Another thing to bear in mind is that, so this antigen, this HRP2, there may be some parasites that have a gene deletion for that, and so they do not express this HRP2. So even if the parasite is present, because this HRP2 is absent, you would not get it on that test result. And so when you do the RDT and it is negative, it is another thing to keep in mind, especially if you have a very high clinical suspicion, to decide to go further and do another test, a different test, to be able to say confidently and conclusively that this is not falciparum malaria, or there's no malaria present. I think I mentioned this about the enzymes and then the HRP2. Okay, and so yes, RDTs may test for the antigens or enzymes individually or in combination. And so you'll find that there are some that are combos. And so there are two test lines and then a control line. And for some of us, we are very quick to say that, oh, this is a very severe form of malaria when the two lines are showing. No, when the two test lines show. No, all it means is that you have a co-infection with something else in addition to the falciparum that is being tested for. Then we come to the management of malaria. What are we required to do? If we've been able to find a patient who has given us a set of symptoms, we suspect it's malaria, we've done our test, and then we've looked at the patient's symptoms and signs and classified and said, oh, there's no vital organ dysfunction. This patient now is classified as having uncomplicated malaria. Such a patient should be given oral artemisinin-based combination therapy. And so there's no room for doing start dose of injection artemether and then go and continue with orals. Or we give a start dose of an IV artesunate and say go home and continue with the oral medications. If it is not severe malaria, the treatment is oral ACTs. And then also, if we have classified and said this is severe malaria, then that patient should start with parenteral artesunate or parenteral antimalarials as soon as possible. If once we've said that this is severe malaria, we do not need to wait for the results of the test before we start treating, because this patient has some vital organ dysfunction. And so we can start, and we are at liberty to give 24 hours of our parenteral antimalarials. Even if the first test comes back and it's negative, we can repeat it 12-hourly within a 24-hour period and then see. So you do 3 more tests subsequently to see that the test is truly negative. And as part of our treatment, there has to be some kind of supportive care. So patients with severe malaria, vomiting, everything, may be dehydrated, may need some fluids to be rehydrated, either ORS or IV, depending on the level of dehydration. If they have a fever, we need to control it. If they have headache, bodily pain, some analgesics would be good for them. So all the other things, other symptoms that they may be experiencing, which is making them quite ill, we need to provide some supportive care for that, monitor their vital signs, including their blood sugars. And then counseling and follow-up. Very often, we may withhold some information. I know that it's not very typical of pediatricians, but sometimes, depending on where you're working and the patient load, sometimes giving feedback becomes a bit challenging. But it's important to tell them that you have malaria, and that means that you were bitten by mosquitoes, and so you have to do a bit more to prevent yourself from being bitten by these mosquitoes. And these are the implications. If you have frequent bouts of malaria, with every infection, maybe you may become a little bit more anemic, because in severe forms you may have anemia and all that. So you explain all these things to them as part of the total management of the patient. Now, what are the challenges that we face in diagnosing malaria? So in some facilities, they may say that there's no means of testing. I explained that sometimes the lab, you only have microscopy until maybe 2 p.m. or at best 8 p.m. And then thereafter, there's no access. In some places also, there may be shortages of RDTs, so you may not be able to get it. Or even when you have it, because it's sort of, you bought it on the open market, and so the patient has to pay for it. And if the patient has no means of paying for it, then it means that you won't be able to test. And then the almighty one, where you have all these clinical signs and symptoms that suggest that this could be malaria, but you do your test and there's no evidence of parasitemia. And then sometimes, yeah, we doubt the accuracy of the results that we have obtained, because we say that, oh, the slides, well, it's operator dependent. So you'll say that, well, depends on who is looking at the slides. So talk to the person at the lab, talk to the head of the laboratory, tell them, this is my suspicion. I strongly think that this could be malaria. Can you have somebody else or someone also take a look at it? Can you yourself take a look at it? Who's your malaria certified microscopist? Can that person take a look at this slide for me so I can be certain of what it is that I have obtained? So as I mentioned, you need first to classify severe or uncomplicated malaria. In that way, you clearly know which pathway you are going to go with regards to your management and in getting your results back. So for severe malaria, do not necessarily have to have your results back before you make that diagnosis. They have symptoms, they have a vital organ dysfunction. You start your parenteral antimalarials because you are thinking it's severe malaria. Uncomplicated malaria, you need to have your results back that say that this person has a positive parasite, and then you treat. Now, another thing that you need to troubleshoot is whether there are errors with the testing procedure. So I mentioned that we're doing microscopy. The slides have to be prepared in a particular way. They take a particular duration of time to fix, to stain, to observe under the microscope, read a certain number of fields and all that. And then they need to do both thick and thin films. So if you're sending patients to the lab and within 15 minutes they are back with a blood film that says no malaria parasite seen, you should investigate further. You should go further and find out what test was done. What really did they do at the lab to give you that results back? And then if it was an RDT, find out how many drops of the buffer were used. Each manufacturer has its own specifications. So how many drops of the buffer were used? How much blood was used? Most of them would say 5 microliters of blood. It seems like something very little, but that is what is able to react with the antibodies that are impregnated on the cassette. And so if you use too much, you will have that prozone effect where you have so many of the antigens and very few antibodies to react with. And so nobody gets to react with the antibodies. And then your test may be seen as negative. Sometimes we use the wrong buffer. Sometimes it's a single container and then it's lost and we can't find it. So we end up using tap water, distilled water, normal saline, anything. But it's a special buffer that is made so that it can lyse the red blood cells, release the antigens to cross-react so that you get the test that you need. And for some of us, we may say that, oh, the tests, usually we are used to, once we add the buffer, the control line shows. And if the control line shows, then the test line must also show. So if the test line doesn't show immediately, the control line shows, then we think that the test is wrong. But it is not so. Every manufacturer has a time period within which the test should be read. So within 15 minutes, some to 20 minutes, some 30 minutes, wait for the appropriate time before you read it. Otherwise, your test will become positive after you have put it in the dustbin. If you are still not convinced, as I mentioned, maybe it's not falciparum and you've done an RDT, go ahead and do a blood film. Look for the Ovali or Vivax or whatever else it may be other than the falciparum. Either you can choose to repeat the same test following the correct procedure or do a different test in order to confirm or say that what it is that you have done was actually right. And like I mentioned, other species may be the cause of the infection. And really, if the test is negative, go back to the history. Take a better history, do a thorough physical exam, look at everything, the ears, the throat, the skin, everything. Examine, listen to the chest, take time to palpate the abdomen, look for other things that could explain the symptoms that the patient is having. Sometimes you may say that, especially for us as pediatricians, we're always concerned about cost. That who is going to pay for these tests? They are going to do all these repeat tests. Who is going to pay for them? But would you rather treat your patient for something that he has than give him medication because this seems like something very simple to treat? I can just give you ACTs for something that you don't have when we are missing out on their diagnosis. And sometimes you want to find out, okay, will this patient return? Especially when you've seen them on outpatient basis. They live far away, they've come all the way, they've queued to come and see you, and now you're done. And then they are asking, will they return? Yes, they probably will, especially if you are especially if you have examined them thoroughly. If you have done a good physical exam and they are sure and they say that, oh, the doctor really examined me. So when he explained that it was not malaria, I was convinced, and they will come at the time that you need them to come. But when they just sit in front of you, give you a few complaints and you write a lab test plus prescription for them, whatever you tell them, they feel that they didn't really get seen by you. And so they may take it with a pinch of salt, other than going with you for what it is that you are saying. Okay. And then in the management, I mentioned that we have to give orals for uncomplicated malaria. In pediatrics, sometimes the children vomit because the medicine tastes horrible. And so that child will eat anything. You give them food. It's not like they are vomiting persistently. They are okay. It's just that when you give them the medication, they vomit that. Give them any food, it will stay down. But the medication, they would vomit it. How do we deal with that? Sometimes it's because they may have a high pill burden. So they've been given something for fever, the anti-malarial, some vitamins, something for a cough, something for appetite, so many things. And they are given all these medications at the same time. So maybe spacing it out may help them to retain it. And sometimes just a little bit of motivation. The Von Trapp family says that a little, just a spoonful of honey makes the medicine go down. So maybe motivates them with something sweet so that the medicine stays down. And then when the patient's symptoms improve, so sometimes you may have a child that's coming very lethargic, you say severe malaria, you give your first dose, by the 8th hour, you're going to give your second dose. He's all over the place. Should you continue and give the second and the third parenteral doses? Yes. And then if the patient, on the other hand, now has a higher parasite count than when you started, maybe you started IV artesunate, now the patient doesn't seem to be doing well, you repeated your parasite count and it's even increased, add on IV quinine. You can continue and then manage this patient and be sure that you are looking at all the other details, urine output, heart rate, all of those things, and monitoring. And then if the patient is pressurizing you, so for example, sometimes they come and they themselves tell you that, doctor, I have malaria. And then now you're saying, he said, I know my body, I know how I feel when I have malaria. And he's telling you, he's giving you a clue, but you're saying that, oh, there's no evidence of it, so I cannot treat you for malaria. It takes a little bit of convincing, be able to win them over and give them the assurance that they can always come back if there's any problem within the shortest possible time. So what is the way forward? We all have to be acquainted with our national guidelines and the updated guidelines. In every facility, there's a malaria focal person. We have to be in touch with that person. We have to see what is happening. Sometimes the training has been done for a couple of people, but it hasn't descended to everyone. We have house officers that rotate very frequently. Sometimes our nurses also rotate very frequently. So doing the RDC may be handed down to one generation, but then the next will not receive it. So we need to be acquainted with what is going on and then make sure that if there are updates, it gets passed on to everyone. Then be interested in which malaria tests were done. So if you have a patient you are seeing and they say, oh, we did malaria negative, find out, was it RDT, was it microscopy, and how did they get the results? If we are convinced that they followed protocol and everything, get in touch with your malaria focal person, let them know we bought a batch of test kits and all of them are giving us negative, but when we do the blood film, we get positives. We will look into it and that helps to build a better system. Then provide feedback. So through your malaria focal person or even directly to the NMEP, be interested in things that are going on with malaria and participate. Then let's advocate for more public education that is aimed at malaria prevention. And then better tasting medicines, because when the medicines don't taste nice, it's difficult for the children to take it. And then we should be interested in how we are reporting, particularly the information that goes on the DIMS. What we are doing in our facilities. When we say that somebody has died of malaria, let it be a true reflection that truly it was malaria that killed this person and not just something that was left to chance. So in conclusion, I want to emphasize that all suspected cases of malaria must be tested for malaria. And then if you have uncomplicated malaria, you are supposed to treat with oral ACTs and parenterals for severe malaria. Then if you have a test results that you are not too sure of because of your high clinical suspicion, explore if there were possible sources of error with the testing process and repeat the test. There's room to do that. And then also treat your patients for the actual diagnosis. So you have to have a list of differential diagnoses. In 2016, in the German district in Braunhavel region, there was an outbreak of a febrile illness where people were reporting symptoms that seemed like malaria. I think the first 3 patients went to hospital, had a malaria test done for the symptoms that they presented, was negative, but they were given anti-malarials anyway. They went home, still weren't getting better, returned only to die. And then awareness was created and we started screening for meningitis, and there we had a meningitis outbreak. And again, this year we reported some cases of dengue fever. With dengue, the patients did not die, but they were very ill. They had symptoms similar to malaria, but they noticed that even though they had symptoms like malaria, it took longer for them to recover, and they were more sick than they were when they had malaria. And yet all the malaria tests were negative and they still got anti-malarials. And so it is at that point where we feel that, oh, it's not working, it's malaria, it's not working, but the tests are negative. That is where now we look into it and want to do further tests. And then now we pick up that it is dengue. We've had Marburg virus confirmed in Ghana. We've had dengue, we've had COVID. At a point, we even described the COVID that came in December of 2021. We said the coughing malaria. And so there are many things that look like malaria, but may not be malaria. So please, whether to treat or not to treat, I have given you some points to consider. We can discuss further so that we know. But the program and the recommended guidelines are telling us that we must test everyone and be sure that they have malaria before we treat them for malaria. So together, let's make malaria a zero. Let's make Ghana malaria free and work to improve the outcomes for the children under our care. Thank you very much. These are my references. If there are any questions or comments, we'll take them at the question session. Thank you very much, and over.
Thank you so much, Dr. Adeline. This has been a very extensive and then very comprehensive presentation. And already there are questions in the chat box for you. So I think while the second one is ongoing, probably you could fish those out and then start answering them before we come to the...
Sure. All right,
yes,
I'll do that.
So thank you so much. It's been a very wonderful presentation. So we'll move on to the next presentation. But before that, let's take note that, yes, this program is CPD accredited, but we need you to be on the Zoom for at least the presentations before we can accredit you. So we'll be putting up a link in the comment section, a Google form link where you would have to fill to get your CPD points, because we don't want people just registering and then joining for a minute and leaving. We want to have the impact. So shortly we'll put up a link for registration for the CPD, and then there will be another form that will come in later for the evaluation of the whole session. So please don't leave the meeting. We want you to have the full benefit of the meeting. And if you have any questions, like mentioned earlier, please put them in the comment section, the chat box, so that Dr. Adeline can fish them and then answer them as we prepare to have our next presentation. Yeah, so as Prof. Anton is preparing to share his screen, we'll have our next presentation by Prof. Anson. I mean, for those who know Prof. Anson, you know that he's a household name when it comes to malaria. He has vast experience in managing malaria, been practicing as a pediatrician for well over 20 years. And I mean, currently there's even a trial ongoing, the SMART trial on malaria, and he is the principal investigator. So you can see that he truly has a lot of linkage when it comes to malaria, and he's my boss. So without much ado, I would want to introduce Prof. Daniel Anson as he takes us through the next presentation on malaria in young infants in Ghana. Prof, please, over to you.
Right, Michael, thank you very much, and thank you for the compliments. We have a very good opportunity to have listened to Adeline for her very comprehensive information on malaria. That is very comprehensive enough such that I would have to abridge some of my messages on this particular topic. I hope my slide is showing. We would have to give recognition to Novartis and the Pediatric Society of Ghana for hosting this program for a minimum of, on average, I'm seeing about 500 participants online. And this is very impressive. And I think we would want to congratulate the Pediatric Society for achieving such a very high number of participation. Now, what is it that we're looking at? We're looking at malaria in young infants. And you realize that Adeline gave us very important information about what malaria is doing, its burden and its impact on our economy. The younger infants, or the very young infant also, is another population that we tend to overlook. And I'm going to make a case for the burden for us to also, those who come close to young infants, to be able to pay attention and manage them very well. The representation will therefore look at the burden of malaria in young infants, malaria in the neonate and the infant, that is those less than 6 years to be 6 months in particular, impact of malaria in pregnancy, because you realize that it is in pregnancy that it translates to the newborn. And so the impact in pregnancy has a significant complication on the newborn. General signs and symptoms that has been outlined by Adeline very well. malaria in pregnancy, outcomes, diagnostic challenges also well articulated by the previous speaker, and challenges in the treatment in young infants. And then what are the prevention? Because we have challenges in treatment in young infants, then we must be focusing on how to prevent this disease. The epidemiology is quite clear that we had over 249 million cases, and in that 608 deaths in 85 countries, and that Africa had the greatest portion of these deaths. And in sub-Saharan Africa, you would have realized that children under 5 accounted for more than 80% in our region. Ghana, as it is a malaria endemic area. Even though the National Malaria Elimination Program is aiming at malaria elimination, we had about 14% in children under 5. Children under 5, it's critical because which criteria is it? Children under 5 can be less than 6 months, 6 months to 1 year, 1 year to 2 years, and 2 years and to 5. And I'll be showing a slide shortly for you to see the burden of the disease in newborn. Globally, in infants and in neonates, the burden varies. It is estimated to be 0.1 to 0.6, but it's because you've put the whole globe together. But when you come to country specific, it ranges from 3.7% to around 21% in countries like Benin, Gambia, and Guinea-Bissau. And these figures are very important depending on the endemicity of the disease in the region, as well as even in the locality, and in Ghana, in the district and the sub-district. Malaria in the young infant may be asymptomatic, and that is where we tend to lose most of our patients when they come symptomatic, because they would come with very severe anemia. Asymptomatic malaria is associated with losing blood at a gradual rate, and when it becomes symptomatic, then you would have a newborn, a young infant coming in with complicated malaria like severe anemia, and without blood transfusion, the patient will die. The low density infections can also present with the anemia, as I said, and its complications is always life-threatening. Now, this data is from the National Malaria Elimination Program. And if you look at children or newborns less than 28 days, as we classify as neonates, from 2019 to 2023, you would realize that we have a minimum of 5,000 cases presenting in the country. And if you look at 1 year to 11 months, we're ranking around the 200,000 figure. It means that the disease in young infants is very important and is very critical for us pediatricians to pay attention to and be very alert and with high levels of suspicion as we manage them. Now, we will realize that there is what we call congenital malaria. Malaria is transmitted from pregnancy to the newborn through the placenta. And the figures are like this: 12.7 million or 36% of all pregnancies were exposed to malaria infections. And so if such high levels of pregnancy are exposed to malaria infections in Africa, you would be able to have an idea about what it is translates to in the newborn. In West Africa, it's about 39.3%, whilst in Central Africa, about 41.1%. And this figure, I think, are the highest in the sub-region. Malaria in pregnancy in the WHO sub-region is looking at about 6.4 million cases, representing 39.3 as indicated already, out of the 16.2 million pregnancies that were at malaria infections. Obviously, it will have an impact on the pregnancy. What are the general clinical features as outlined in a previous speaker? Fever, anemia, splenomegaly, and other symptoms like jaundice, vomiting, and diarrhea, poor feeding, restlessness, drowsiness, respiratory distress, cyanosis, and convulsions. These are all organ-specific complications that we are seeing here in terms of symptomatology. But in the newborn, this usually is mimicked at neonatal sepsis. Newborn sepsis is sepsis. And we either would not test well or start antibiotics. So there is a problem with not testing and inappropriately giving artemisinin derivatives, as well as not also doing blood culture and sensitivity and looking out for the source of infections and giving antibiotics. So we are like, we go straight away to both ways, antibiotics plus anti-malaria at the same time. And one of them, we clinicians are sure that we are wrong in one, because one, our culture is not available. We are unable to do culture in most of the health facilities, and our RDTs was not done. We do not have the microscopist, and so we tend to shoot both directions. So if you have a neonate, the neonate may be lucky, clinicians may stick to infections, and till the last minute when they said, okay, then let's try anti-malaria, and it works. The important thing is that we need to test, treat, and track as recommended by WHO, and we'll talk about that shortly. Now, what are the impacts or the outcome of malaria in pregnancy? Low birth weight. In fact, when you find a mother give birth to a child who is low birth weight at term, suspect that the mother probably had multiple malaria infections during pregnancy, because malaria in pregnancy has a significant impact on the placental growth and placental health. And therefore, low birth weight is one of the common complications that we see. Prematurity, it's associated with premature delivery, and therefore prematurity is one. And in tertiary institutions where you see a lot of prematurity, we haven't done enough research work to be able to say what is the proportion or what is the association between prematurity and maternal malaria. And that is a very important study that we need evidence-based information to be able to enforce preventive practices that I will talk about shortly. Stillbirth and neonatal deaths are all part of the outcomes or complications that we see. Growth retardation and cognitive impairment. The extent to which malaria causes cognitive impairment and growth retardation, it's overwhelming. Evidence is clear, but we are not trying to identify these potential risk factors and making advocacy for very good coverage for malaria in pregnancy. Now, one thing on the block is neural tube defect. Recurrent malaria in pregnancy would associate itself with neural tube defect because of the need for folic acid supplementation. And so if maternal nutrition is not good, then neural tube defect has been strongly associated with malaria during pregnancy. Now, I've mentioned the figures already, so I won't overbear. However, it is important to note that we can prevent this with IPT. And you realize that it was estimated that about 914,000 units would be born with low birth weight if we hadn't implemented IPT, which has reduced the figure to 393,000 units, according to the WHO report. The sub-Saharan Africa always carries the highest burden of this low birth weight. And low birth weight, is associated with a high under 5 mortality, malnutrition, and early under 5 deaths. This figure is very important for us to look at. The first one is looking at malaria infections in pregnancy. And the yellow or orange shades gives the proportion that were without infections and the proportion of pregnancies that were with infections. And in 2021, 2022, you realize that the West Coast or the West African sub-region has the highest. When you come to mothers who are on IPT, malaria with IPT and malaria without IPT, you realize again, it's been recognized that in sub-Saharan Africa, we are the highest, that we do not take the IPT serious. Meanwhile, the IPT has been found to reduce all the complications that we have mentioned. And I'll show a presentation or a study that has proven that with repeated more than 2 doses of the IPT. What is it that we need to do? The recommendations are clear. The 3 T's: test, treat, and track. And this is a recommendation by the National Malaria Elimination Program. This is because, one, we don't want to waste the artemisinin and even create drug resistance, as well as making sure that we are giving the right medication for the right diagnosis. You will realize that in the neonate, it is only our microscopy that is recommended, because you find out that there would be a false positive microscopy, RDT, in the sense that some of the HRP2 and PLDH may be transmitted to the neonate, and therefore may be mistakenly to be positive in the neonatal period and treat wrongly. Meanwhile, the child is dying from neonatal or early sepsis. Therefore, we need to be very mindful that in the National Malaria Elimination Program, it recommends microscopy in the newborn or in the neonate. How many regions within the country would be able to do microscopy? And that is where the problem is in terms of the challenges we face in malaria. The resource availability, health facilities, experienced microscopists are not available. And in some places where there's microscopists are available, the timing is also not favorable for the test. And therefore, we always have this problem on our hands. What are the challenges in the neonate? In neonates, newborns usually weigh less than 5 kilos. Meanwhile, we are aware that the treatment for artesunate management is for children above 5 kilos. And therefore, we tend to give the same dose or give half the recommended dose for children 5 kilos, which is a very important thing. I'm aware Novartis is coming up with a new formulation that can cater for this population. And that is what is bringing our attention there. Once you identify the patient, give the right treatment, give the right doses, and track the patient, because you treat well and you track your patient. Tracking your patient means that you must follow up on the patient, because it has also been found in other cases that post-artesunate treatment is associated with anemia. And therefore, tracking your patient is very important in the management of the malaria. This study, and I'll recommend each and everyone to read. Increased systemic exposure of artemether and dihydroartemisinin in infants under 5 with uncomplicated malaria. The fact is that it was found to be efficacious. That is, the study was found to be reducing the parasites. However, the toxicity levels in the under 5 kg is still a problem. And therefore, when we are giving it in this category, we must be very careful. That is why some clinicians would want to give half the dose for children newborns less than 5 kilos. But you realize that is not evidence-based. It's just based on your own thing that, okay, don't let me give too much. But we need to be very careful. We're going to be lucky to have a product that is tailored towards this age group, and so that we'll do the right thing for this category of patients. What are the issues? The issues is that the newborn or the young infant has slow gastric emptying, immature enzymes, and the dosing also is not appropriate. And these are the 3 main factors that we are dealing with malaria in the young infant. And it is very important that we be careful and pay attention to what is in the literature and give the right doses at the right time. In the current situation where we do not have the medications that are tailored to this, the management of newborns and children younger with weight less than 5 is still a major problem. Challenges again that we have, the off-label use. We think that, okay, let's look at it and adjust. Sometimes we adjust based on even our own formulation without even any evidence. There is limited information on the use of the combination therapy for young infants, and this is a major problem that we clinicians should be covered. The need for evidence-based guidelines. We would want to support every clinical research or trial that would want to look at the dosing, the right dosing for the, rather than giving the same dose that we give to the children more than 5 kg to children less than 5 kg. It is not the same that we need to do. We therefore should aim at prevention. The current preventive measures are the intermittent preventive treatment in infants, where anti-malarial that are given during routine immunizations is recommended. But the most important one is during the pregnancy, where at the 2nd trimester, the 3rd trimester, mothers are allowed or are requested to take the SP. And the current WHO practice is to take SP every month till delivery. However, I'll show the next slide with recent studies, what recent studies is telling us. Again, the seasonal malaria control program that is well practiced in the northern part of the country is also another important intervention that would save lives. The center in Kintampo have actually looked at the effectiveness of intermittent preventive treatment in pregnancy on the WHO recommendations of monthly till delivery versus a minimum of 3 to 4 doses. And the study revealed that when you give 3 to 4 doses, it is as better as giving more than the 3 to 4 doses. Again, giving either 1 dose or 2 doses during pregnancy, it's associated with high risk of low birth weight and all the other complications that are associated with. And so the current recommendation is that give minimum of 3 to 4 doses during pregnancy in the second and third trimester to be able to reduce all the complications that are associated in pregnancy. Other complications that we are, preventions that we have noted as the malaria vaccine that is currently available. There are 2 malaria vaccines currently on the market recommended by the WHO, the RTSS vaccine and the R21 vaccines. Those are all infant vaccines that Ghana will be deploying the RTSS vaccines. There has been a pilot implementation in 3 regions in Ghana. And so Ghana is ever ready for the malaria vaccine, and it will further boost the effort of the National Malaria Elimination Program. Again, the National Malaria Elimination Program is also promoting the post-discharge malaria chemoprophylaxis. It is aimed at preventing new malaria infections and reinfections in children admitted with malaria, severe anemia during the period after hospitalization or discharge. And it's another very important recommendation. I've spoken about the seasonal malaria control. These are efforts that we need to aim and highlight and as well as promote, because we currently do not have a very good treatment for the children less than 5. Thank you very much.
Thank you so much, Prof. Another very enlightening presentation. And then I think a lot of the misconceptions we've had about pediatric or infant malaria has been cleared in terms of what can be given and what cannot be given. Thank you very much, Prof. Anson, for the elaborate presentation. And please, I can see a lot of the questions are being answered in the chat box. So, I mean, there are so many. So if yours is not gotten to your turn yet, please be patient. And then there are people also complaining about challenges with filling the forms. I don't know, the form is working very well for most people, so I'm surprised there are still challenges. But if you have any issues, please, there's been a number put up in the chat box. You can contact and then we'll see how best we can help resolve that. So thank you once again, Prof. If there are any questions for Prof. Anson as well, please, it will be difficult to take so many questions on voice. So as many as can type in the chat box, that will be preferred so that we can handle the questions rather there. So in order to save time, we'll quickly move on to our next presentation. Because of our time factor, we will not have a session strictly for question and answers, because like I said, there are 500 people on the call. So if I ask people to raise their hands, it will be difficult to tell who to pick and who not to pick. So please type your questions in the box, in the chat box. We'll take our final presentation from Novartis, and they are the leaders when it comes to anti-malarials, and they have been supporting us for the entire year in our presentations, our malaria presentation, CPD accredited malaria presentations. So we'll invite Novartis to give us a short presentation on what they have for us when it comes to malaria, what is new. And Prof mentioned that they were planning something new formulations for infants. So in the next few minutes, they will tell us what they have and then how they can also help. So, Novartis, if you are ready, we are also ready for you.
Hi, so thanks so much, Dr. Commensa, and I'd like to acknowledge Dr. Asante Kwabe and Prof. Daniel also for their very insightful presentations. So for us, it won't be a presentation. So for this session, we'll be conducting a short survey on malaria in infants. So I don't know if you have your phones, you can scan the QR codes. If you are not unable to scan the QR code, I've dropped the link for the survey in the chat box, so you can click on the link in order to access the survey. So the objective of the link is to um, help us gather insight into the various diagnostic practices and therapeutic approach for the management of malaria in neonates. As you all know, there's limited real-world data available on the diagnosis and management of malaria in this vulnerable population. So the objective of this survey is to help bridge that gap, and would want to assure you that it's completely anonymous. Your responses will remain confidential, and it's a very short survey. In less than 5 minutes, you can complete the survey. So to access it, kindly scan the QR code, or you can click on the link provided in the chat box. So I'll give us 5 minutes for us to complete the survey together. Yeah. So if you have any issues with the survey, you can drop your questions in the chat box and we'll address it. But it's pretty straightforward, and you don't have to type much. So Dr. Commensa, so I don't know if Prof or Dr. Asante Kwabia can take their questions whilst the participants
Yes, I think
answer the survey
Dr.
questions.
Santokabe, if you could, as you've gone through, select ones that you think would need to, because I just realized those on YouTube are unable to see the responses in the chat. So I think it will be, there are so many of them, we can't pick
One
all of them.
question.
Yes, so once you can select,
Pregnant
then
women take malaria vaccine with the IPT. There are currently no malaria vaccines for pregnancy. So it's for children, for infants. Please, we have some instances that patients test negative for RDT, no MP seen on microscope, but patients end up getting better after treating malaria. That one is treatment by chance, in the sense that if RDT is negative and microscopy is negative, it could be a self-limiting viral infection that this child might have, and so would become well with or without the artesunate or your treatment. Once both are negative, you probably look out for other causes as outlined, UTI, otitis media, tonsillitis. Other viral infections can present with fever and may end up like that. So how long does it take malaria microscope to be ready? If you have a very good expert, malaria, you take the slide, you dry it for 5 to 10 minutes, you take it under a microscope. Within 30 minutes, you should be able to get your microscopy ready, results ready. For how long will it take to get a negative results after treatment? For microscopy, so far as we are doing the serial microscopy, when it's negative, you will see it's negative. Yes, so and your best negative, malaria negative, is microscopy. For the RDTs, it is unpredictable. And so if you want to say the patient is negative, then it's microscopy. So the treatment for the neonate is still a problem, because we still are doing off-label treatment. The current label treatment that we are giving is not evidence-based because of the toxicity. We are aware for dihydroartemisinin and the actimeter component in the children less than 5. And we currently going to have a production that is tailored towards the actual dose for artemeter and the lumefantrine. And so that is the current update on treatment in less than 5. What we're doing is off-label, and we're subjecting our children or our newborns into risk of neurotoxicity. The malaria vaccine will be free. It's part of the national EPI program. It will be free and it will be deployed nationwide. The pilot implementation that was done in Ho, the Bunahaf region, and the central region was to test or to evaluate the implementation logistics, and that one has been successfully been done. And I think in January, the malaria vaccine, the RTSS vaccine, will be rolled nationwide.
Okay, there's a question that says, in patients who appear to have improved after treatment, but they are still MPs, do we do watchful waiting? And if so, how long? And how long does it clear every single parasite from the blood after treatment? So for those who, it depends on, so within what period are they coming back with the parasite still present? Is it within the 3 days of taking the ACTs, or you mean so typically within the first, if they are treated and within 28 days or less, they have parasites, we consider that it's probably the initial infection they had, which has not been properly treated. So now we need to know, was it because the medication they took was not appropriate, or adequate? Was the dose not appropriate? Were any doses skipped? Was there any vomiting, any dose that was not absorbed? So you need to explore all of these to be able to say that, okay, that infection was not well treated. And if it was not well treated, is it because the medication that they took. So even if it was absorbed and all that, was it of poor quality or whatever. So again, in the guidelines, we have first-line anti-malarials, artesunate amodiaquine, artemether-lumefantrine, and now we have artesunate pyronaridine for the first line. Then our second line, dihydroartemisinin piperaquine. So if you find that the problem was that they skipped the dose or it was not properly absorbed, you can repeat any of the first lines. If they have taken the first line as they should and still did not clear the parasites, you can give them the second line. If it is positivity after 28 days of the first infection, then now we can think of a new infection that they may have acquired, in which case now you treat as a new infection. How long does it take to clear the parasites from the blood after treatment? So typically the parasites in the asexual phase, you would clear by the time you've taken your 3 days of your ACTs. Sometimes you may have gametocytes remaining because the ACTs do not target the gametocytes. So gametocytes may still be present.
Okay. So I'm trying to fish through to see if there are any questions that have been skipped. Whilst this is ongoing, I hope we are, Novartis, I hope you are getting responses for the survey, because that's very key. And for those who are done with the survey, please, we need your feedback so we can do better in subsequent CMEs or CPDs. So there, we've put in the chat box the evaluation link, the link to the evaluation. So please do well to fill that for us as well. So your feedback is very important for us to help us perform better subsequently. So please fill the forms. Okay, so trying to see if, okay, I think this has been answered already, whether there is an upper limit to the dose of IV artesunate. So it is weight-based. So there is no specific upper limit cap. It's based on the weight of the patient. So if you calculate the dose per kilo, whatever you get is what you give. I realize a lot of people put a cap, especially for adults, they give 120, irrespective of the weight. So please, there is no upper limit cap on artesunate. Okay. Yeah, so someone is asking if there is room for presuming malaria and treating units who have been transfused. So for units who have been blood transfused, who have received blood transfusion.
No, it is not a good practice. It is still blind treatment. Make sure you testing for microscopy and before you treat. Even after 15, 20 years ago, when we are going to do an exchange transfusion on a newborn, we were giving anti-malaria and antibiotics prophylactically. No, that is not the way to go. It's not evidence-based.
Okay, thank you so much, Prof. Okay, going through, I think most of the questions have been answered.
Yes, I think there was one question about how the automated parasite analyzers compare with blood film. And I said, I don't have much information on that, so I'll look into that. I know there are a few facilities currently that are using it, so I'll look into that, and then maybe I can share the information on the Pediatric Society page. Thank you.
Okay. So I hope after this, those who are in the habit of giving IM at the meter start and then completing with, or else you would advise yourselves and then I saw a question about why artesunate is preferred, and I think that has been answered by Dr. Adeline as well. Okay. Please, if you have asked a question and then you've not received any response yet, you can let me know in a direct message so that we can have that addressed. Because the messages are a lot, it's difficult scanning through to pick out those that have not been answered. But you would all agree with me that it's been a very insightful presentation. Both presenters have done extremely well, and we've all added new knowledge on our malaria diagnosis and treatment. So please, our evaluation forms, they are as important as the CPD forms you filled. So please fill them for us. And then the CPD registration form, please ensure that you fill the form before the meeting ends. After the meeting has ended, the link will take no more responses. So for the CPDs, please try and fill the forms before the meeting ends.
A question, someone asking a question says, can anti-malaria medicines be taken concurrently with hematinics? Please elaborate your response. Okay, yes. If the patient is pale or is anemic and you transfuse, that is one way of managing the anemia. On the other hand, if the patient would require hematinics, you can still start your folic acid and probably your vitamins. And if the patient obviously have microcytic anemia and you are sure that there is iron deficiency, then you can add your hematinics. Paying attention that the patient doesn't have any bacterial infections the time you are treating, because there can be severe malaria with secondary gram-negative sepsis that when you give hematinics at that time with iron, you're likely to worsen the patient's presentation.
Yeah, so those asking about the presentations, PSG will work on that, and so some of these presentations will have to decide later whether it can be shared. So if it will be, since you registered with your email, you get the presentations in your email. So rest assured, if we have the go ahead, once you registered, you get the presentations in your mails.
Dr. Mensah.
Yes, please.
Please, there's a question on YouTube. It says, how do we know if the reduced incidence of new malaria infections or reinfections in children with severe anemia on PDMC is not due to the effect or other malaria programs interventions?
Prof, please, I don't know if you got the question clearly, whether you could take that for us.
Michael, what was the question?
All right, can you please repeat the question? If I'm unable to go to the YouTube too.
Okay, please. Someone is asking on YouTube, how do we know if the reduced incidence of new malaria infections or reinfections in children with severe anemia on PDMC is not due to the effect of other malaria programs interventions?
So he would want to find out whether the impact of the PDM, the post-malaria prophylaxis, has on the overall national decline in malaria in Ghana.
He wants to know if the reduced incidence of new malaria infections or infections in children that have severe anemia is not due to the effect of other malaria interventions.
Okay, so yes. So malaria control there are several tools currently the National Malaria Elimination Program is considering. It starts from the IPTI, the ISMC in the northern region where there are seasonal control of this malaria, as well as the current post-malaria prophylaxis. And now the additional tool that is going to be added, the malaria vaccines. All these are coming together as tools that will reduce the malaria infections and probably transmission in higher areas of endemicity. So it will be very difficult to pinpoint that this tool alone is the one that was the magic wand in reducing the incidents.
Thank you.
Right. Welcome.
Hello.
Hello.
Okay. I think there was, I don't know whether I could be heard earlier, but
We can hear you now.
I hope I can
please.
be heard now because I was
Yes,
trying
please.
to speak earlier, but it wasn't. Okay. All right. Okay. Thank you. Sorry for the break. There was a little mishap with my internet. So I don't know if Prof answered the question earlier, because my internet dropped.
Yes, please, he did.
All right. Okay. Thank you. Thank you so much, Prof. So, Novartis, I'm not, please, do you have enough responses? Because we are almost nearing the end of the presentation. So,
Yes, please, Dr. Mensah. So, for those who are not able to take part in the survey, we'll share the link with the PhD admin so that it will be posted on the platform for them to also take part in the survey. But for now, I think we can close if you want to.
all right. Okay. Thank you. Thank you so much. So, I think we are just 9 minutes shy from 6. It's been a wonderful evening spent. And personally, I think I've also learned a lot. And if your questions were not answered, It's unfortunate we can't answer all the questions because there are so many messages. You could link up with any of the PSG executives or in the various pages we are on, and then I'm sure the questions can be addressed there. So thank you for joining this CME, organized by PSG with support from Novartis, and then also by the Pediatric Infectious Disease Subgroup of PSG. We want to specially thank our presenters, Dr. Adeline and then Prof. Anson, for the very, very extensive, well-prepared presentation and all the explanations given. We are very grateful. And then we are hoping that in the coming year, we'll have even a lot more CMEs on malaria. So on behalf of the national executives, I'm not sure if any of them could join, but I think there was another meeting they had to also join. So we are grateful for your time, and we hope to see you in the next sessions. Thank you so much. Yes, so we are done for the evening.